Thank you, Chantry, and thank you everyone for joining. For those who haven't seen me on one of these sessions in the past few months, my name is Drew. I'm one of our clinical infectious diseases pharmacists at WVU Medicine Ruby Memorial Hospital in Morgantown, West Virginia. Today, I really just put together a handful of slides to maybe elicit some thoughts from the group at large on a couple of different scenarios in which we find ourselves either empirically or maybe even definitively considering combination antimicrobial therapy, which could be the case for a number of different infections, maybe a polymicrobial infection, but for the purposes of today, we're going to talk a little bit about persistent Staph aureus bacteremia, which has been featured in a number of our topics over the past several months, necrotizing fasciitis, and then those odder or I guess rare cases of gram-negative infective endocarditis, which don't always come up a ton, but there isn't a ton of published guidance on how to go about treating them. So the first thing I wanted to briefly touch on was persistent Staph aureus BSI. That could be either MSSA or MRSA. The definition for what's considered persistent in the literature has evolved over the last 10 to 20 years. Historically, and in the most recently published guidance by Infectious Diseases Society of America, recommend defining persistence with Staph aureus bacteremia as 7 or more days of positive blood cultures. Now that's been nearly 10 years, probably 10 years at this point since that was published. And more literature up front is suggesting possibly an early use of combination antimicrobial therapy to help clear blood cultures in these patients with high inoculum Staph aureus infections presenting with bacteremia. So the reason of bacteremia could be persistent, we can think of a number of things. Maybe it's a valve, either native or prosthetic, that hasn't been operated on, which we would use echocardiography to evaluate a foci of infection in the joint space, either again native or a prosthetic joint. Patients who have retained vascular catheters certainly are at risk for persistent infection if they aren't removed, and that's believed to be a source of infection. And occasionally, Staph aureus can cause abdominal or pelvic infection and abscesses, specifically more so after operative procedures. It's somewhat rare, I would say, to find a typical intra-abdominal process caused by Staph aureus. Aside from, say, something maybe neighboring discitis or an osteomyelitis of the spine. So one recommendation for going about treating these scenarios could be one, dose optimization, and that's something when I'm looking at patients I'm kind of considering first. A lot of times empirically, when someone sees a gram-positive cocci clusters in a blood culture, we'll start them on vancomycin, per se, without any further information. And it does take several days for that drug to reach steady state concentrations in the serum. Beyond that, the empiric dose that we choose, depending on a number of factors, baseline renal function, a patient's weight, may demonstrate low serum concentrations at time of steady state 3 to 4 days into therapy. So one of the issues that I have rationalizing with vancomycin sometimes in these cases is, one, they may have been started on the drug 3 or 4 days ago, but it could have been a suboptimal dose resulting in subtherapeutic levels. I think that's why I often, in cases where appropriate, like daptomycin empirically, of starting with a monomicrobial or monotherapy therapeutic agent, because we were a little more assured that serum concentrations will reach the steady state they need to eradicate infection quicker than vanc. Beyond dose optimization, though, is the concept of combination therapy in either the case of MSSA or MRSA, and that could be, say, cefazolin and oxacillin, plus ertapenem is what's been most routinely studied mostly retrospectively at this point. Although we have some investigators on a trial that can speak more to a prospective approach. The same with daptomycin, which is often combined with ceftaroline or vancomycin and ceftaroline in cases of persistent bacteremia. Typically, we can, our practice here and what has been reported elsewhere is to consider monotherapy after about 72 hours of clear blood cultures, whatever form that takes, whether it be oral therapy if it's appropriate for a patient, or IV daptomycin, ceftaroline individually, vancomycin individually, on a kind of a case-by-case basis, considering site of infection and other patient characteristics to ensure the definitive strategy is optimal. So it's a broad question, but if you want to throw in the chat or briefly speak out, is there any kind of cutoff or timeline that you as a practitioner have used in the past for considering, say, adding a second agent when treating persistent Staph aureus bacteremia? Not seen any responses in the chat. Do you all have any thoughts on the topic?
So I think there is a lot of variability. This is one of the data gaps in terms of not very good guidance on when should you add the second agent, those kind of questions. I do see even within our own group a variability in terms of some are very comfortable starting with vancomycin up front. I think others may be a bit jaded with vanc and tend to start with dapto up front. My challenge with persistent Staph aureus bacteremia first is in its definition. For other bugs, 2 consecutive blood cultures positive may be persistent, but for Staph aureus, we seem to say it's okay till day 7. How did we come to that number? Should it be 5 days? Should it be smaller? So I think one of my challenges there. I think the key point you mentioned is the opportunity for source control. If you can control the source early, fast, that probably has the biggest impact on how long somebody remains bacteremic. That's why we want to study this question, whether we should be approaching it with 2 drugs up front versus a single drug.
Thanks, Katessa, for your input. Similar assess for persistent infection that may need source control. Thank you. Next is just a brief, it's a challenge that we face here. It may be different elsewhere for those listening, in that in cases of necrotizing fasciitis caused by group A streptococci, certainly an organism most commonly implicated, we can see that other causes, Staph aureus, they may be polymicrobial and whatnot. But the concern with group A streptococci is the production of exotoxin that can cause some severe systemic complications, severe septic shock. Historically, here locally, we have used clindamycin as an adjunctive agent to prevent exotoxin production. Recently, though, linezolid's been somewhat advocated for, certainly through our own local institutional guidelines, because we take a look at our antibiogram, we see an extremely high rate of group A strep resistance to clindamycin, 80% or more is what's been noted. And so for that, we had considered linezolid as an alternative, in which again, pretty much all of our strains of strep pyogenes are going to be linezolid susceptible. There's some variation or question in the literature that if you're just using the agent for exotoxin neutralization, then does it necessarily need to be active against the bacteria itself? We don't really have any good data for an answer to that question in human studies. There is some out there in say animal models. But for that reason, I've found in the last 2 to 3 years up front when considering an adjunctive agent for this specific indication in necrotizing fasciitis, we favor linezolid over mycin in many scenarios. So this is what maybe a empiric regimen may look like. Something, again, it could be a polymicrobial infection. So before we have maybe some good OR culture data or blood cultures result to suggest a certain pathogen like group A strep, could use a broader empiric regimen like this. So one other thing that is also kind of undetermined, I think I've seen a variety of approaches just following patients here, has been the time to discontinue anti-exotoxin therapy. So maybe linezolid is our definitive choice in some cases because it works well to cover whatever organism's been isolated in an OR culture or a blood culture. But in cases of, say, where we feel we could use a narrower agent, and say a broad gram-positive agent like linezolid, or if we were using clindamycin in this scenario, when would you all consider discontinuing exotoxin?
I know for me, Drew, and you kind of touched on this, it kind of depends on what my exotoxin therapy is. Uh, that's one of the reasons I like to use linezolid instead of clindamycin, because usually if I'm treating a polymicrobial infection, starting out with the linezolid and Zosyn or linezolid cefepime and flagyl, I'm done. I don't really have to do any more thought on in terms of when I should stop my exotoxin therapy.
Yeah, I like what Contessa and Rachel have both posted. I think that's pretty consistent with what I see. A lot of times these patients go to 2, 3, 4 trips to the OR to adequately address the infection. And occasionally, after maybe say that last trip, we know they're clinically stable, say not in an ICU somewhere, 2 to 3 days afterwards, the exotoxin coverage is discontinued if not needed for some other purpose.
Clinically, agree with 48 to 72 hours. At the patient's bedside, there are a few indicators that tell you they're no longer toxic. Their tachycardia is resolved. That's one of the biggest indicators that you tend to see at about 48, 72 hours. And the other one that I've noticed over the years is their liver enzymes tend to start normalizing. A lot of patients with shock or a lot of exotoxin-mediated sepsis syndromes tend to have elevated liver enzymes, and that tends to normalize around the 48 to 72-hour mark.
You all. And just lastly, because I think this is an interesting topic in itself, simply because of the lack of guidance that we have from reputable sources such as the IDSA, European societies that have published guidance even more recently than 2015. But say we're treating a patient with gram-negative infective endocarditis. What's recommended 10 years ago by the IDSA was that combination antibiotic therapy for 6 weeks, say aminoglycoside or fluoroquinolone, is reasonable. And that's about all that's expounded upon that. There's not a ton of literature providing rationale for that recommendation. It seems to be more expert consensus when those guidance were published. In 2023, like I said, the European Society of Cardiology had recommended treatment early with early surgery and prolonged therapy with a combination of beta-lactam and aminoglycosides, sometimes with additional quinolones or trim sulfide. So just that was a brief summarization of what's out there. But what is the group's approach to how you go about becoming a gram-negative infective endocarditis? Sometimes I feel our local practice can be driven by a pathogen per se. I think Pseudomonas infective endocarditis seems quite rare, but a lot of times when I've seen it, someone's persistently been bacteremic, say, especially if they got offered further source control procedure or valvuloplasty or whatnot. So I'm curious to hear the group's thoughts on these scenarios. Surgical trial. I think, yeah, that's the one thing that seems to be definitively stated in both of those guidance statements is the need for surgical intervention.
Yeah, completely agree with you. In terms of endocarditis, we think of it as a medical disease, but that's really with gram positives. That's where you can talk about some endocarditis can be treated medically, mostly in the gram positive, but if you have candida endocarditis, gram-negative endocarditis, first principle is surgical control. And I think the rest of it is then how adequate was the control, whether you use one or two drugs, but completely agree. This is a surgical disease primarily.
Common gram-negative we see here and our experience at Princeton is Vinceretia,
Correct.
Substance use or injection drug use, especially with surgery with multiple single agent, even going to oral postal.
Well, that's all I have today. Appreciate the input, the discussion, and the thoughts chat here around the table. I'll stop sharing my screen so we can get into cases.